Hello, welcome again to another edition of Matters of the Heart, brought to you by Haverhill Community Television and Pentucket Medical Associates. I'm Seth Bilazarian, a cardiologist with PMA, and I'm joined today by Dr. David Toth, an endocrinologist with our group, whose offices are in Haverhill and in Newburyport. I've invited Dr. Toth to join us today as an endocrinologist who has a special interest in diabetes to talk about diabetic medications. There's been a really explosion of exciting new diabetic treatment options. There have been old ones that are around since the 1950s, like insulin, but the expanding number of medication options has increased, and I actually invited him so he could teach me a little bit about diabetic medications, the options, and how you choose between these different medications. So take it away, David, and tell us what we should be thinking about.
Well, thanks for having me, Seth. You know, your point is very well taken that there are just tons of medications out there for diabetes now. As a matter of fact, just a few months ago, I took a look on a website run by the National Institutes of Health, who, basically look at all of these trials of medications that are coming out, and they listed the number of diabetes medications that were being studied. That aren't ready for prime time yet. They're not for patient use yet. They're not approved, but these are medications that are being studied, and there are now a grand total of 75 different medications that are being studied for diabetes. Now you could compare that to cancer drugs. Right now there's about 150 cancer drugs, and that's for all different types of cancers. All different types of cancers, and only one disease when you compare that to diabetes. That's a tremendous amount of medications that are being studied. And I think the reason why we have all of these medications and all of these options is because diabetes is such an exploding epidemic in the country. It's estimated that anybody born in the year 2000 has a 1 in 3 risk of having diabetes by the time they're 40 years old. That's just tremendous. If a third of our population is going to have diabetes sometime in the next 30 years, it's something that we have to do something about, not only preventatively, but also something we have to do about when the time comes and when these people show up on our doorsteps and in our offices. We have to be able to offer them some great treatments to prevent bad things from happening. And I know that we're going to talk a little bit more about, in another episode, about different complications when it comes to diabetes, and especially cardiovascular complications. But, I think right now it's an exciting time to be an endocrinologist because we do have a lot of options of things that we can use for diabetes medications.
Great. So take us through, how should we talk about these? Should we talk about them from like older groups to newer groups, or how do you want to talk about or do we even have time to cover them? Because you said there's a lot of these medicines, but should we talk to them on by groups of medicines, or how should we do that?
I think talking to them about by groups of medications is probably the easiest thing to do, because right now there's about 6 different groups of medications, and if we talked about the 50 or 60 odd medications individually, I think we would be here for about 3 or 4 hours,
Sure.
and people would probably tune us out.
Sure.
But if we just talk about groups of medications, that's probably a good idea.
Great.
The one I'll start with, if we're going to start with groups of medications, is a medication that's been around in the United States since the mid-90s, but has been actually used in Europe since the 1950s, and it's a medication called Metformin. And the reason I'm going to start with that one is Metformin is right now the medication that's the go-to medication in terms of somebody that's newly diagnosed with diabetes. Right now, the American Diabetes Association and their European counterpart as well has said that everybody that's diagnosed with diabetes, the first time they're diagnosed, the first time they show up, they should all be placed on Metformin, unless they can't tolerate the medication. I'll talk about that in a second too. But Metformin is a great medication because it does a couple of things. One thing our bodies do when we have diabetes is we make extra sugar. Our bodies always make sugar. Our bodies are always trying to convert the different fuels to sugar, because some of our tissues, especially our brains, the only thing they can use as fuel is sugar, is glucose. So our body tries to convert this, and the conversion mostly happens in the liver. So what metformin does is it actually slows down that conversion of other fuels into sugar, into glucose. So that's how it lowers the blood sugars. The liver primarily does that in between meals and especially at nighttime, in between times that we're not eating, so that we can have an adequate supply of glucose for our brains to work. But we don't want to do it at an extended period. We don't want to do it at an extended rate because that's what drives the blood sugars up. So metformin does a great job of kind of shutting the liver down a little bit in terms of its sugar production so that our blood sugars can stay a little low. It also is a great medication because it's been proven to prevent cardiovascular disease, or at least reduce the risk of cardiovascular disease. So I think in those two instances, plus the fact that the medication is generic right now, and you can even go to pharmacies that have these $4 or $6 medication plans, and you'll see them on that for $4 or $6 a month. This is a great, cheap, well worthwhile medication to be placed on. Any medication is going to have potential risks and side effects, and each time I talk about a class, I do want to mention those as well. And metformin is one that's notwithstanding in that regard. The biggest risk for metformin is that it can cause a very rare but serious side effect called lactic acidosis. And this is a side effect that happens, like I said, very rarely, but what happens is it can cause muscle breakdown. And patients can get very, very severe muscle aches all over their body and actually can go into kidney failure, even liver failure. That happens exceedingly rarely. In somebody that has diabetes that takes metformin, it's probably 1 out of every 50,000 or 1 out of every 100,000 people that will get a side effect like this. So it's a very, very low risk. That risk does go up if somebody is older or somebody has problems with their kidneys, if their kidneys aren't functioning properly. So that's something that I always look at and other physicians always look at. We want to look at and see what the kidney function is before we start a medication like this. And if we think the kidney function is compromised enough, we might want to shy away from this, even though it is an excellent medication. And in patients that are older, it's a little controversial. Right now in the United States, the general recommendation is that anybody over the age of 75 or 80, definitely above the age of 80, probably shouldn't be on metformin anymore. Europeans kind of laugh at that because over in Europe, they put people on this all the time, and they keep people on this throughout their 80s into their 90s, and they say they haven't seen a problem. I guess we're a little more cautious here, and knowing that we have other options.
Okay, so let me briefly summarize what I think you taught us all about metformin. So metformin, it's a drug that also used to be called glucophage for people who remember the brand name of that drug, but it's now generically available. You said it's cheap. It's recommended as a first step. It does, I think you said, 3 good things for our sugar control. It blocks the amount of sugar that our liver makes to try to keep our sugar level low, our sugar level steady. You said it blocks the amount of sugar that we absorb. And you said that it actually makes us more sensitive to our insulin. So it does those 3 good things. So it's a good first choice with pretty low rates of problems.
Very, very low rates of problems, and that's why that's another reason why it's a first-line choice.
Great. What's next?
Well, unfortunately, most people that have diabetes are going to need more than one medication, and diabetes, I always tell people, is a moving target. It's something that we're always having to constantly change things around and mix things up, so we're keeping people under good control. Next, I'm going to talk about an older class of medications called the sulfonylurea medications. And these are medications that used to be called brand names like Micronase, Diabeta,
Glyburide.
Glyburide is a generic one, and I think that was the generic of Micronase. Glucotrol was another brand name, and that now is generic. That's glipizide, and the other generic is glimepiride. And these are the 3 medications in that class. They're oldies but goodies in some respect. They do a very, very nice job of lowering blood sugar. And that's primarily why these medications were developed. What these medications do is, if we can kind of picture that they squeeze extra insulin out of the pancreas. They just make the pancreas make more insulin, especially in response to a meal. because that's primarily when we need insulin a little bit more, when we need our bodies to produce insulin a little bit more, because when we're eating a meal, our blood sugar will rise very high if our pancreases aren't making enough insulin. So these medications try to get our pancreases to make more insulin, to keep the blood sugars lower, to lower the blood sugars. The unfortunate thing with these medications is, they're not very smart medications. These medications will just keep squeezing insulin out of the pancreas. So the biggest risk for these medications is that they can actually cause low blood sugars. If they squeeze too much insulin out of the pancreas, or squeeze insulin out of the pancreas in times when we're not eating or we're spending a lot of time in between meals, we're going to have very, very low blood sugars in between. So one of the biggest risks is for hypoglycemia or low blood sugars. And one of the biggest risks for, that somebody can get with hypoglycemia is accidents. Hypoglycemia or low blood sugars are the #1 cause of accidents in people with diabetes. So this is something we definitely want to prevent. There's also a lot of interesting evidence that says that the more times somebody goes into hypoglycemia or low blood sugar, they might be at higher risk for having heart problems, having cardiovascular disease, heart attacks, or irregular heart rhythms, something you'd be very, very interested in. So another reason why we'd want to prevent these low blood sugars from happening. The other thing that these medications do, again, they're constantly squeezing insulin out of the pancreas. You got a picture that these are kind of like putting the gas pedal down on your automobile, so you're constantly trying to keep the engine running at full speed. Well, if you keep an automobile engine running at full speed, it's going to burn out very, very quickly. The same thing, unfortunately, happens to the pancreas when you use these medications. The pancreas tends to burn out and lose its own insulin-producing ability.
So you didn't give a very, the first medicine, Metformin, you said a lot of really nice things to say, but on the sulfonylurea, you said it's really good at lowering blood sugar, but then from there on, you didn't say a lot of nice things about that group. So I guess I just asked to teach me, why do we use these drugs at all then? Well,
I think there's a couple of reasons why we use these drugs. Again, #1, they do a very good job of lowering blood sugars, and for some people, if we can keep blood sugars at a reasonable rate with medications like this, it might be an acceptable second-line medication to use. The other reason why they're good medications are they are generic medications, so they are also relatively cheap. But again, they can come at a price for low blood sugars, or maybe the possibility of increased cardiovascular risks, or especially the increased risk of having the pancreas burn itself out a lot quicker than it should.
Okay. So the metformin, we talked about 3 ways it works to help with sugars. You said sulfonylurea pretty much only works by boosting up the amount of insulin. What's next? What other options do we have?
Well, luckily in the past several years, we've come up with some other great options. And one other option that's been around now for about 12 years is a medication class called the TZDs. The long name for that is thiazolidinediones, and I don't expect anyone to try and spell that, but I'm sure it'd be worth a lot of points in Scrabble. The TZD medications, the first one was Resulin, which has long been taken off the market because that was shown to have an increased risk for liver problems. But the 2 that are on the market right now, at least for right now, are a medication called Avandia, and the generic name of that is rosiglitazone, and Actos, and the generic name of that is pioglitazone. And even though these are medications that are in the same class, they do seem to, and they kind of work the same way, they do seem to have different benefits and different risks associated with them. So I'm going to touch on that. So first of all, the way these medications work, the way the TZD medications work in general as a class, is they increase our sensitivity to insulin, whether someone's taking extra insulin or whether we're relying on our pancreas's own insulin to be made. These medications increase our sensitivity to insulin, so our pancreases don't have to work so hard. We can require less insulin to still get the job done of lowering blood sugars. So they do a really, really good job of that. The difference, one of the differences between Actos and Avandia, or pioglitazone and rosiglitazone, is that Actos seems to have added benefit of possibly lowering LDL cholesterol, which is also known as the bad cholesterol, and especially triglyceride levels. Not to a great extent, but at least to some extent that could be beneficial, especially in preventing cardiovascular risk and stroke prevention. Having said that, these medications shouldn't be used alone for preventing heart attacks or lowering cholesterol, and especially Avandia, because Avandia has gotten a lot of press in the past couple of years because there was one study that looked sort of retrospectively or looked backwards at people that were using Avandia over a long period of time, and it actually showed that people that were using Avandia had probably a higher risk of having heart attacks. It's hard to say why this was, if it was because people's blood sugars were going too low or because it was the medication itself, but I think there was enough evidence that caused the Food and Drug Administration to say, hey, wait a second here, let's stop and re-examine this. So they've been doing that over the past 12 to 18 months, and finally in the past month or two came out with the recommendation that said, we're going to strictly restrict the use of Avandia and only have it used in people who absolutely positively need it, which are very, very harsh words and really should make people, physicians, pause before they start writing for a medication like or the medication Avandia. Actose, they don't have that same restriction on. It doesn't seem to have the same bad effects, but certainly that's something that's being watched and something that's being looked at very, very carefully. The biggest risk for these two medications, too, the other biggest risk is that it can cause increased fluid retention, especially when you use it in medications that either boost the insulin, like the sulfonylurea medications that I just talked about, or insulin itself. If you use it in conjunction with this, people tend to get lots and lots of fluid retention, so they might notice some swelling in the legs, weight gain. Weight gain can be reported as much as 10, 20, or even 30 pounds from these medications. And anytime there's an increased fluid retention, it raises your risk for either having congestive heart failure or can worsen somebody who already has congestive heart failure. So we definitely do not use these medications in people who have any history of congestive heart failure. And we strongly think about using these medications or think about not using these medications in people that are using sulfonylureas or insulin.
Okay, so just you told us about metformin. You had a lot of enthusiasm. You gave that high marks. Then you told us about sulfonylureas. I got the flavor that there's a little less enthusiasm. Then you went even lower on these groups of medicines called TZDs. They have their place, but there was a little less enthusiasm. Can you turn this around? Give us another one. Give us a fourth group of medicines that might be even better.
Well, the latest research in diabetes has shown that diabetes is not insulin alone. We always think about insulin as the hormone that controls diabetes and controls blood sugars.
Well, take a moment and just tell us about that. So you eat, hopefully you're not eating a candy bar, but you eat anything, has some sugar in it, goes into our stomach, goes into the bloodstream, the sugar level goes up, take it away.
So then what happens, actually, as our bodies are, as we're eating, as we're taking in fuel, it even goes even before that, a step before that. Our pancreases get signaled by our gut, by our intestines and our stomach that says, hey, there's a meal here, there's some fuel that we're starting to digest. You better give us some insulin. And insulin is sort of the key that unlocks the tissues in our body to help the fuel go where it's supposed to. Otherwise, it's just going to hang around in the bloodstream and cause our blood sugars to go up. So so the pancreas will increase the insulin production whenever we're starting to eat and whenever we're eating and digesting a meal and taking in that fuel. So we thought for a long time that insulin was the main player in terms of lowering blood sugars. Insulin was it. But we discovered that there was another hormone back about 20 years ago called GLP-1. This hormone is actually produced by the gut. It's produced by the intestines. And this hormone actually acts a couple of different ways. It tells the pancreas, it's probably the hormone that tells the pancreas, hey, start producing insulin. It's also the hormone that tells the gut, let's digest things at a nice, slow, even rate so we're not all of a sudden taking in all this fuel and spiking the blood sugar up and going out of control. And the third and very important thing that it does, it tells our brains that we're full. It goes up to tell our brains that, we've eaten a meal, we're not hungry anymore. Something that people with diabetes will tell us a lot is they will tell us, I'll eat a meal and I know that I eat what I'm supposed to be eating, but 5 minutes later, I'm still hungry. I feel like I need to eat more. And it's probably because of a lack of production or a lack of action of this hormone called GLP-1. So there are a couple of different types of medications that were designed with this hormone in mind. The first one is that I'll talk about are medications called the DPP-4 inhibitors. And these are oral medications. There's two on the market right now. The one that was first on the market was a medication called Januvia, and there's another one on the market called Onglyza. There are others that are trying to come on the market, and like I said before, there are lots of medications in development, and there are actually 5 other of these DPP-4 inhibitors in development currently right now, being looked at in various trials. So this is just to show that it's a very important area and a very important medication class that we need to look at. So the way these medications work, what DPP-4 does, what these DPP-4 inhibitors do, I should say, is these medications block our bodies from breaking down that GLP-1 hormone. What happens, unfortunately, is GLP-1 is a hormone that gets produced and washes away very, very quickly within a matter of minutes. So even if we're producing it at a meal, it constantly has to be produced and produced and produced. So these medications actually block the breakdown of the hormone, so the levels of the hormone can actually rise a little bit. And that's where we get some positive effects on increased insulin production, slightly better digestion, and maybe telling our brains to stop eating a little bit as well. So these medications used by themselves can lower the blood sugar probably about 20 to 30 points. If we use them in combinations with medications like Metformin, they can lower the blood sugar as much as 50 or 60 points. So these can be very powerful medications and definitely have a good place in use for diabetes.
Okay. Tell us, you've been doing a great job telling us what we should be cautious about with different medicines. What can you tell us about these medicines? You
know, the interesting thing about these medications, right now, and again, these are newer medications. They've only been on the market now, Januvia being the first one, for about 5 years, but they don't seem to have a high risk of side effects. They don't seem to have a high risk of bad things that will happen to you if you take these medications. One of the side effects that's rare is allergy, and that's the only one that seems to be reported with it. These medications are even safe for people who have severe kidney damage and can be used in people that are on dialysis, as a matter of fact. Okay. So these seem to be very safe medications.
Okay. Now, there was some medicines in this group that aren't really DPP-4 inhibitors, but they're injectable medicines. Can you tell us a little bit about those and what your thoughts are about those?
Absolutely. So there's 2 injectables of this type right now, and what they do is they mimic this hormone called GLP-1. The first one that was on the market is some medication called Byetta, and the one that's been on the market now since February of this year is a medication called Victoza. So Byetta and Victoza mimic the hormone GLP-1 that's normally produced in our guts. So it actually, it's kind of like the body producing excessive amounts of this, which is actually a good thing because they're very powerful in lowering blood sugar and can lower blood sugars by as much as 40 or 50 points. These medications, so they're even a little more powerful than the oral medications like Januvia and Onglyza. And most people, not everybody, but probably about 80% of people that use these medications will actually lose weight. And we know that weight loss in people with diabetes is something that we always struggle with, but something we always tell our patients that they have to do and must do. So these are medications that can be used very successfully, not only to lower blood sugars, but also to help people lose weight.
Anything bad to say about them that we should be cautious about?
You know, the biggest side effect that people seem to get with these medications is nausea. Nausea happens about 30 to 40% of the time in people that use these medications, but it's something that for most people doesn't seem to last. If we use these medications for about a week and use it at a low dose, people seem to get to tolerate it a little bit better, and the nausea feelings tend to disappear. So it's something that I always tell people, if you're going to experience it, you're going to experience it for about a week. But if you experience it for longer than a week, maybe it's not a medication that you can tolerate. But that's a very small percentage of people.
This is fantastic. So you're teaching me a lot. I'm very excited to learn all that you've shared with us. But we're running out of time, and I'm going to ask you in very short order to just tell us a few words about insulin And I'll just say that a lot of patients are afraid they don't want to go on insulin, but can you tell us briefly about what would be something we can encourage patients to at least not have such a negative idea about insulin?
Well, I always tell people that insulin gets a bad rap, and people have what's called Aunt Tilly syndrome with insulin, because everybody remembers what happened to Aunt Tilly when she went on insulin. She got blind, she got a heart attack, she lost her legs, she went on dialysis. All these bad things happened to Aunt Tilly. That was years and years ago when we never used insulin early enough in the diagnosis of diabetes, and we didn't have very good insulins to use. Insulin is by far the best drug for lowering blood sugars. It lowers blood sugars. The sky's the limit. It can lower the blood sugars no matter what, and however much we want them to be lowered. Insulin is something that probably everybody with type 2 diabetes needs to be on eventually. Eventually the pancreas is going to burn itself out and not make any insulin, and eventually everyone's going to need to be on insulin. And that's not a bad thing, because insulin prevents the complications from diabetes from happening. It prevents blindness, it prevents kidney disease, it can even it can prevent amputations. It can prevent the big complications from diabetes from happening. So it's not a bad medication.
And the insulin needles are so good now, they don't even hurt to give yourself an injection.
They don't. People are shocked when I show people how to give themselves an injection, and I do it on myself. They cringe, but I show them. I poke myself a couple of times, and I show them, this doesn't hurt me at all, and it's not going to hurt you either.